So, hello everybody again. Welcome to the MGH Cancer Center COVID and Cancer Zoomcast series. Today I have Eric Rosenberg, who is in the Department of Pathology and is going to talk to us today about testing. So, Eric, tell us where you're from, how you got to this particular position you're in.
Yeah, no, thanks, Dave. It's really a great opportunity to be able to talk to the Cancer Center family and share not only a little bit about who I am, but where we've come from in terms of testing. So my name is Eric Rosenberg, and I am an infectious disease physician. I take care primarily of individuals who have infections related to transplantation. But in the other role that I play, I'm the director of the clinical microbiology lab at Massachusetts General Hospital. And so it's really in this role that I'm coming to try to share our experience with you about testing.
Terrific. So COVID-19, obviously it's a virus. So when we say testing, like, what do you mean by testing? What are we actually testing?
Yeah, and it's a really important question because I think whenever you turn on the news, you're hearing all kinds of phraseology about this test or that test and what we don't have, what we need more of. And so really to demystify this whole, problem around testing, I thought it would be helpful to break down the two types of tests that we currently have. And the way that I think about it is that there's really two very different buckets of tests available to try to either diagnose somebody with COVID-19 or figure out whether or not they've been exposed to it. So the first category of testing is to try to directly detect the presence of living virus. And if we can do that, then that unfortunately means a patient is infected with COVID-19. And so whenever you hear that somebody had a PCR test, that's exactly what that PCR test is trying to do, is detect the presence of living virus. The second bucket of tests that we have are called antibody tests or serologies. And this is a totally different flavor test, also very important, but plays a different role in how we're using it to diagnose COVID-19. So the first thing to understand about an antibody test is that the human body will produce antibodies in response to any virus that enters the human body. And antibodies are really just a very complex protein made by the immune system that will bind to a virus if it sees it, and then try to eliminate the virus from the body. So we can utilize a strategy of trying to detect if antibodies are present to better understand if somebody has actually been infected with COVID-19. And so those are the two big buckets of testing.
And so right now, the PCR or polymerase chain reaction test, that exists, and our patients can go get that at one of the respiratory clinics that we've set up. So that's pretty straightforward, I think, although it gets pretty complicated about what's a positive and what's a negative test.
And we can talk about that.
So if I'm positive, I assume I'm positive, but if I'm negative, am I really negative?
Yeah. So, and the answer, unfortunately, is if you're negative, you're likely to be negative with a couple of caveats.
Okay.
And the first caveat is that it's not a perfect test. Mm-hmm. And so sometimes somebody will actually be infected with COVID-19, and for various reasons, the test reads negative. And so a negative test does not rule out that somebody's been infected with COVID-19. A positive test almost certainly means that you are infected with COVID-19. So let me just kind of put that into perspective. Mm-hmm. It's probably about 90% of all people who truly have COVID-19 and have symptoms related to COVID-19, that if you do the PCR test, and we can talk about what that test is and how it's done, but about 90% of those people will test positive as long as the test is performed correctly and the specimen that's inserted up into the nose is obtained properly.
Okay.
So the good news is we'll make the diagnosis in 9 out of 10 people. The unfortunate news is that there's always 1 out of 10 people who will turn out to be or read negative when in fact they're positive. And so the strategy for people who are really ill is to wait a few days and retest again. Once we retest with a second swab, about 98% or 98 out of 100 people will turn up positive with the second swab. And so if somebody's ill, they're hospitalized, they're immunocompromised, and we really can't afford to get the diagnosis wrong, we'll do 2 tests. If somebody's at home and they're just not feeling well, they have the flu, it's not as, the harm by not making that diagnosis is not as great. So maybe that category of person would only need 1 test.
Now, I've heard of people recently who are feeling fine. Maybe they had some mild illness, they tested positive, and they want to go back to work, and they get another test, and they keep being positive, and now it's a month later and they're still positive. So if you're positive, what does that mean going forward? Is that the same as, does the flu do that?
Yeah. So really, so the short answer is that we don't know the answer, but let me try to put it in a little bit of context. The PCR-based test is detecting nucleic acids or genetic material from the virus. And so we know that when virus takes hold and the virus is reproducing itself in the airway, the test is always, or should always be, positive. What we don't know is after that virus is actually come and gone, or the virus is dead, are we still able to detect genetic signatures from the virus, not because the virus is still there, but because the test is so sensitive at picking up these nucleic acids that the test remains positive for a long time. And we simply don't know, is the virus still there and still infectious to some, or is the virus dead and gone, but our test is so sensitive that we're still picking it up? I can tell you that in the case of the flu, we can detect viral nucleic acids, viral genetic material, sometimes several weeks after somebody's completely recovered from the flu. And when you try to grow that specimen in culture, nothing grows, suggesting that the virus is no longer there.
Got it. Got it.
So
let's switch then to the blood-based tests. So the serology. So tell me now, is it always an antibody test, or sometimes do you actually look for virus in the actual blood test, like some of those nucleic acids or other viral particles?
So as of now, the virus is predominantly in the airways. So in the nose, in the back of the mouth, in the airways, all the way down into the lungs. It really doesn't. It really does not show up in the bloodstream in detectable quantities. So the PCR test is really restricted to the nasal swab or the oral swab, not the blood. The test that we do in the blood is the serologies, or the antibody test. And it's really this, instead of detecting the virus itself, when we're looking for antibodies, we're detecting the body's response to the virus. And so whenever virus enters the body, the nose, the airway, the immune system, the human defense, is to try to put out little soldiers to bind virus. The first responder is an antibody called IgM. And this is an antibody that comes up usually by 7 or so days after infection and does its best to fight off virus. Over the next few days, the body will start to make even more sophisticated and better antibody called IgG, which will then come and replace the initial responder, the IgM. IgG may persist for the rest of somebody's life. So for example, Dave, if you had chickenpox as a child, I could draw your blood right now and we can find IgG in your bloodstream directly targeting the chickenpox. We think we'll be able to do that with COVID-19, but it's just too early and we don't know.
Okay.
So that's the first question. The second question is, does the presence of these antibodies mean that you're protected from future infection with COVID-19? And again, that's an unresolved question. We don't know. I'm keeping my fingers crossed and hoping so, but until we have that information, we just don't know whether somebody can be reinfected or not.
So I understand that MGH went out and tested some communities. So what did the initial test show in those communities?
So it's really interesting, and what we've learned is that where the virus has hot zones or hot pockets where it's much more common and spreading in different areas of the community more quickly. And so we know that we had a group of investigators who went out and literally stood on a street corner in a busy Massachusetts city and voluntarily asked people if they wanted to have a little finger prick test where the fingers prick, do you have a little drop of blood, and they can try to detect whether there's antibody present. Mm-hmm. And what they found is that I think it was over 30% of people who had no symptoms were just walking by on the street. Over 30% of people in that community actually tested positive for antibodies to COVID-19. If you went to a different town, it might be much, much lower, or it could even be higher. And so that's just one use of antibody testing, is to try to find where the hot spots are. And I think that's probably right now the best use for antibody testing.
Now, can you quantify these antibody testings, or is it just a positive or a negative result? Either you have it or don't, or is it quantifiable in some way?
Right. So the current tests that we have, it's just, yes, you have it, no, you don't. The next generation of tests, which you're going to hear about, which are called Eliza-based tests, will be able to quantify titers. And that's the next big step towards trying to understand if antibody protects you from infection or not. Because we need to know how much of the antibody you have, what's your antibody titer, in order to start understanding whether or not it's protective, and at what level do you have to have in order to assume that you're protected.
So what kind of timeline are you talking about until MGH starts, I guess maybe with the first serologies, first starts testing, say, everybody who walks into Mass General, and then what's the next timeline for when MGH starts testing anybody at any time, the way we would order up, say, a Lyme antibody test or something like that?
Right. So the first step is that we do have a serology test available at Mass General. It detects the two types of antibodies we talked about, IgM, which comes up within the first week or so, and then IgG, which comes up a little bit later, but should stay a lot longer.
Okay.
We have that test available, but the way that we're using it is only in very sick, hospitalized patients who are testing negative by the nasal PCR swab.
Got it.
And so because we know that the PCR test turns positive first, and then that test begins to decline as the antibody test comes up. So there's going to be a subset of people who are PCR negative that we can make the diagnosis based on the presence of antibodies. We can do that now for sick people who are in the hospital. We don't have the capability to do that for everybody who's just curious. Like, was I infected? I'm not in the hospital, I'm feeling fine, but was I infected when I had a cold? We don't have the ability to do that now, but I suspect in the ensuing, 2, 4, 6 weeks, as the hospital and the outpatient practices begin to really open up again, we'll have the ability to bring that test forward. I think one of the things that is I'm very curious. Like, I had a cough 3 weeks ago. Did I have COVID? I kind of hope I did because I'm fine, but I'm pretty sure I didn't. And so I would go ahead and get the test, and then I'd be very disappointed if it was negative. And I think a lot of people are probably going to be disappointed when their antibody test is negative.
Got it. Got it. And the Eliza, how far away are we for the Eliza on a routine clinical basis?
So the Eliza should be available for our inpatients probably within the next week. And unlike the test that we're doing now, which is that finger prick test, and you basically put a drop of blood on something that looks like a little pregnancy test, the Eliza can be done in a much higher throughput. So we'll be able to ramp up and do more testing on the Eliza. And then as we ramp up that throughput, we're going to be able to extend that testing to outpatients. You know, the other thing that I should probably add, because most people listening to our conversation are going to be members of the cancer center family. The other thing that we should talk about is that when you're trying to measure antibody, it's a reflection of the immune system. And so there may very well be different chemotherapies that people are getting, which may dampen down or lessen that antibody response. And so these tests, although we're going to hope that they're as robust as they can be, may even be less sensitive in people who've received therapies that are immunosuppressive in some way.
Right, right. And then lastly, do you have to go through any FDA process to get these approved, or can MGH just stand it up on its own?
Yeah, so a little bit of both. So when we developed the PCR test, one of the, we stood up testing. We were the very first hospital in Massachusetts to stand up a PCR test. We started developing it on March 6th, and then on Friday, March 13th, we went live and had our own in-house developed test. And one of the disappointing things along the way is that we were unable to get the exact reagents that the CDC had, which were approved by the Food and Drug Administration for use. And we kept on waiting for them and waiting for them. And when they never showed up, we said, you know what, we just have to take action into our own hands and develop this test in-house. And so what that implies is that we had to do a very extensive in-house validation. And then we took the data that we generated and we submitted it to the FDA for FDA approval. And we were one of the first 3 or 4 academic health centers to have their in-house assay approved by the FDA. Same is true of, so we're approved and up and running on everything we do is for PCR testing is FDA approved. And we now have 4 different assays that we do for PCR testing in order to be able to have enough throughput to do enough tests to do all the patients who need testing. Antibody testing is going to be much the same, and we're currently generating the data to submit to the FDA for what's called EUA, or emergency use authorization or approval. And so we're working on that, but we're allowed to test while we're applying for that sort of FDA approval.
But you can't bill for it, is that correct? If it's under,
to be determined,
FDA approved? Yeah.
To be determined. Most payers have already approved paying for the test. Although I'm definitely not an expert in how the payer system works. I suspect that what we're hearing from the government is that just do the testing and we'll figure out how to pay for it later. And so I hope that that's ultimately what happens. And I think anybody who's listening to this who really needs a test is going to get tested regardless. And then we'll just figure it out down the road.
So of all the clinical trials that you're involved with right now, what's the 1 or 2 that you are dying to find out the results to?
I think that there's 2 tests, there are 2 clinical trials that I'm really curious about. One, we've heard some preliminary data regarding, and that's this antiviral drug called remdesivir. Mm-hmm. And it's an interesting drug because it was developed by one of the big pharmaceutical companies because people thought it would have activity against Ebola. And that turned out not to be true, where remdesivir doesn't work for Ebola. But this company had this drug, and when MERS, which is the Middle Eastern Respiratory Syndrome, which is a very close cousin to COVID-19, when MERS came up a few years ago, it started to look like this drug may have activity against MERS. And so then when COVID-19 came along, they thought, it makes sense to try to test this. And so this clinical trial has been open. It's a National Institute of Allergy and Infectious Disease clinical trial. There's multiple sites across the country. MGH was one of the very first enrollers in this randomized clinical remdesivir study. And right now, I believe there's 1,000 patients who've been enrolled.
Right.
And the analysis of the first 500 patients was revealed last week. And it showed that even though this isn't a magic cure, which nobody expected it would be, that people who were randomized to getting treated with remdesivir were able to leave the hospital on average after 11 days, rather than if you didn't get remdesivir, it would be 15 or more days. So it seems like the drug is doing something. Mm-hmm. It's at least shortening hospital stay. Although it doesn't seem, if somebody is unfortunately so sick that they're going to die from COVID-19, this doesn't seem to pull people off of that extremis cliff.
Right. Got it.
The other half of the data is being analyzed now, and we should hear some stuff about it really soon.
So it'd be if we knew, for instance, that if there was some change in the serology or some change in the some kind of quantifiable, like some change in the ELISA, it might act as a biomarker for us for future clinical trials, and we get our answers a little bit more quickly.
It might, and probably when you're treating people with very acute severe disease, it may be more the PCR test, where if a drug really worked, it would stop the virus from reproducing or replicating, and you might see PCR tests go from positive to negative.
Got it.
That would be a biological marker. And the antibody test may play a role, but that would be less clear what the antibody test would do.
Got it. Well, that's terrific. If you could, last question is, if you have any advice for the Cancer Center public out there, what would it be?
So I think there's a few things that I would say. One is that this is scary times, but there's ways that we can protect ourselves from getting infected. And for the Cancer Center population, you just have to stay at home and minimize your risk to people who are potentially infectious as much as possible. Remember, just because somebody feels well doesn't mean that they're not able to infect another person with virus, because we know people can shed virus without symptoms. So Cancer Center patients need to take this whole home self-quarantining, social, physical distancing thing really, really seriously. The second thing is that if you do go out in public, it's really important to wear a face mask. And we know that these face masks that we have available outside the hospital are not 100% protective, but they probably do offer some protection if you were in direct contact with another person who is infected. The third thing is that virus can live on surfaces, and we don't know how long, but if you touch a surface and that has virus on it and then touch your face, you're likely to get it. So you always want to wash your hands and use any kind of alcohol-based sanitizer to prevent you from taking virus from a surface and inoculating yourself. And you want to touch your face as little as possible, not when you're home and you're out of harm's way, but if you're out in public, you want to touch your face as little as possible. And then the fourth thing is that it's really important. Everybody's trying to avoid the hospital. Nobody wants to come into the hospital because there's lots of COVID-19 patients in every hospital. But if you're at home and you feel sick, you have to call your doctor and you have to come in, and we're going to take good care of you. and keep you out of harm's way, but don't stay at home and suffer needlessly when you have something that can be easily treated at a hospital.
Got it. Well, that's great advice. And thanks a ton for sharing it with us and sharing your time today, and have a great rest of the week.
Yeah, you too. And everybody stay healthy.